Good morning, everyone. So, the topic of my presentation is supranuclear control of eye movement. So, the contents are we are going to study this in two subheadings supranuclear oculomotor neural pathway, and other is supranuclear eye movement systems. In supranuclear oculomotor neural pathway, there are cortical control centers and subcortical control centers. In supranuclear eye movement systems, there are saccadic system, smooth pursuit eye movement system, Burgess movement system, vestibular eye movement system, optokinetic system, and position maintenance system. So the introduction is eye movements are essential for clear, single, and stable vision. To achieve this, the visual system uses a highly organized hierarchy of neural structures that extend from the cerebral cortex to the brain stem. In this diagram, we see that this is the cranial nerve nuclei, this is cortical center, and this one is the extraocular muscle level. So, from the level of cranial nerve nuclei, above is it is the supranuclear pathway, and below this nucleus level is infranuclear pathway. So, supranuclear control refers to all the structures above the level of the cranial nerve nuclei, and the cranial nerve nuclei we are going to study for the eye movement is third nerve nuclei, fourth nerve nuclei, and sixth nerve nuclei. And the function of the supranuclear control is to plan, initiate, coordinate, and modulate the eye movements. And while the nuclear or intranuclear pathways, their role is limited just to execute the movement. Supranuclear system, it handles the decision making and coordination underlying the different types of ocular motility. These structures have an integrated sensory input with the visual, vestibular, and proprioceptive system and produces precise motor commands that ensure the eyes to move appropriately in response to the environment. So as we have already seen, the hierarchy of the oculomotor control is at the level 2, there is nuclear level, above is supranuclear and below is infranuclear. So level 1, it is supranuclear, level 2 is nuclear, and level 3 is infranuclear. So in level 1, which is supranuclear, it is cerebral cortex, cerebellum, vestibular apparatus, and basal ganglia. At the level 2, that is nuclear, is brainstem nuclei, third, fourth, and sixth cranial nerve nuclei. And at level 3, that is infranuclear, is oculomotor nerve and extraocular muscles. So, as we already know, there are six extraocular muscles which are involved in moving the eye, and they are supplied by the 3, 4th, and 6th nerve. Cranial nerves have their nuclei in the midbrain and at pons level. So we know there are six extraocular muscles, four recti and two oblique muscles, superior rectus, inferior rectus, medial rectus, lateral rectus, and two obliques, that is superior oblique and inferior oblique. So superior rectus, it takes origin from the annulus of Zinn, or say all the recti muscles and oblique, it takes origin from the annulus of Zinn, except the inferior oblique that has origin behind the inferior orbital rim. And if we talk about the insertion, so their insertion is on the sclera and some distance from the limbus. Superior rectus on sclera, it inserted 7.7 mm from the limbus, inferior rectus 6.5 mm from the limbus, medial rectus 5.5 mm from the limbus, lateral rectus 6.9 mm from the limbus, superior oblique 13.7 mm from the limbus, and inferior oblique, it has insertion lateral to the macular area. If we talk about the nerve supply of these muscles, so we know LR6, SO4, and rest all the muscles are supplied by the oculomotor nerve. So, this lateral rectus, it is supplied by the sixth cranial nerve, superior oblique by the fourth cranial nerve, that is trochlear nerve, and rest by the oculomotor nerve. So if we talk about their actions, so the primary action of the medial and lateral rectus, as we know, they have only one action, and that is their primary action. Medial rectus, um, the action is adduction. Lateral rectus, its action is abduction. Superior rectus, its primary action is elevation, and inferior rectus, its depression. In secondary action, superior rectus has intorsion, and tertiary action is adduction. In inferior rectus, secondary action is extorsion, and tertiary action is adduction. If we talk about superior oblique and inferior oblique, so their primary actions is intorsion and extorsion, while secondary actions are depressions and elevations, and tertiary action is abductions. Obliques have tertiary actions of abduction. Now we come to our topic. So firstly, we are going to see what are the types of eye movements. The first eye movement is saccadic. saccades. What are saccades? Saccades, these are conjugate eye movements, these are voluntary eye movements, these are rapid, and that shift the line of sight to bring a new object into the fovea. So in this, we see this is saccadic eye movement. That is, it is conjugate. Conjugate means it is the direction of the eye is in one direction. If one eye is going to the right, then other is going to the left to maintain a one gaze position. Then we have smooth pursuit. It is slow tracking movements to follow the moving objects like this. Slow tracking of the object. Next is vergence. Vergence is the movement of the eye in opposite directions to maintain a single vision at different distances. These distances could be near or far. So, in convergence, eye moves inwards, that is near vision, and in divergence, eye moves outward. So, in this, we can see this is the convergence, and when eyes go away to each other, it is for the distance being of the object. Then we have vestibulo-ocular reflex. It is automatic eye movement that stabilizes gaze during head movement, like this. If head move towards the right, then eye will move toward the left to maintain the gaze during head movement. Then we have optokinetic response. It is the combination of both pursuit and fast saccades, and it is triggered by motion of the entire visual field. In this we can see the surrounding visual field is moving and there are saccadic and pursuit movement in the eye. Next is then the headings we have studied, that is cortical control center, subcortical control center. So in this we are going to study first about the cortical control center. So in cortical control center there are two more centers. One is frontal ocular motor area and other one is parieto-occipito-temporal junction. So what are the function of these areas? This frontal ocular motor area has function for the saccadic eye movement, while this parieto-occipito-temporal junction, it has function for the smooth pursuit eye movements. Next is subcortical control center. So in subcortical control center, we are going to study about the PPRF. This is paramedian reticular formation pontine system, which is located at the pons level. Then we have RIMLF. RIMLF, it is rostral interstitial medial longitudinal fasciculus, and it is located at the level of midbrain. We have posterior commissure, superior colliculus, medial longitudinal fasciculus, convergence and divergence center, vestibular apparatus, and the cerebellum system. These come under the level of subcortical control center. Next, we have these cortical control of eye movements. These are involved in two major reasons. One is frontal ocular motor area. So further, it is divided into four components. One is frontal eye field, supplementary eye field, dorsolateral prefrontal cortex, and posterior eye field. In this, we can see this is supplementary eye field, frontal eye field. We have dorsolateral prefrontal cortex. Then, what is the function of frontal eye field? So the frontal eye field, uh, it is involved in the horizontal saccades and the vertical saccades. But in horizontal saccades, there is stimulation of only one hemisphere, and which is contralateral side, for the conjugate movement of both the eyes to the opposite side. Like if there is movement towards the right side, right gaze movement, then the frontal eye field that is stimulated will be of contralateral side, that is left side. But in vertical saccades, there is equal bilateral FEF stimulation for the vertical gaze. Next is parieto-occipito-temporal junction. Parieto-occipito-temporal junction. It is primarily concerned with the fixation and pursuit movement. So the key cortical areas in parieto-occipito-temporal junction is one is middle temporal visual area and other one is medial temporal visual area. So this middle temporal visual area, it receives visual motion signals from striate and the pre-striate cortex areas, and it sends connections to brain stem pursuit centers. And this medial superior temporal visual area, it works with the middle temporal for processing complex motion. So if we look for a summary, like FEF, it has saccadic movements, fast voluntary eye movements, and horizontal and vertical gaze shift. We have already talked about the supplementary eye fields. that is responsible for planning and sequencing saccades. The dorsolateral prefrontal cortex area, it is responsible for decision making of the saccadic system. The PEF, that is posterior eye field, it is responsible for visual attention and target selection. Then we have MT or MST, it is responsible for smooth pursuit, that is tracking of the slow moving objects. Next is paramedian pontine reticular formation. It is the brain stem structure and it is responsible for generating the horizontal conjugate gaze movement. If we look about the position, it is located ventral to the medial longitudinal fasciculus and it extends from the trochlear nerve nucleus to the abducens nucleus, abducens nerve nucleus. Its extension is from the trochlear nerve nucleus to the abducens nerve nucleus. Then we have rostral nucleus or MLF. It is located at the midbrain level, at level of upper pole of the red nucleus, and it has connections to the motor neurons of oculomotor nucleus and trochlear nucleus as well as to the PPRF. And it has direct connections to the interstitial nucleus of Cajal, and it is important for the vertical saccadic movements. Next is posterior commission. So this is the posterior commission. It is located dorsal to the RIMLF. It is a fibrous tract through which fibers of RIMLF pass to the contralateral side before reaching the oculomotor nerve nucleus and the trochlear nucleus. Next is convergence and divergence center. Divergence center, it has no evidence that any center is located at the level of subcortical center. So it might be controlled by the cortical areas rather than the brainstem centers. Then the convergence center, it is a definite subcortical convergence center is not proven, but it is seen that pretectal areas, these are the most probable site on the basis of the clinical evidence. This is the pretectal area and it is located anteriorly to the superior colliculus at the level of midbrain. Then the motor inputs and the motor outputs. Motor inputs, the convergence signals originate from the frontal lobe, that is frontal eye field, occipital cortex area, and these cortical impulses descend to the oculomotor nuclei. Then if we talk about the motor outputs, so the oculomotor nucleus send impulses via the cranial nerve nuclei third to the medial rectus muscle of both the eyes and activation of both the medial recti that leads to the convergence movement. Next we have superior colliculus. It is located in the dorsal midbrain level and it has a role in both the motor and sensory visual functions. It receives inputs from the directly from the retinal ganglion cell axons and also receives indirect input from the visual cortex, parietal lobe, frontal lobe, and substantia nigra. Efferent projections to the brainstem premotor areas, and its function is to generate visually directed saccadic movement. Then we have vestibular apparatus. Vestibular apparatus, it produces reflex eye movements that stabilizes the gaze during head movement, and these are involuntary fast and these are essential for fixation. The vestibulo-ocular reflex. Components are it is present at the it is a part of the inner ear and it is composed of semicircular canals and saccule and utricle. As we already know that semicircular canals, these are responsible for detecting the rotational head movements, and saccule and utricle, they detect linear acceleration and gravity. Then we have medial longitudinal fasciculus. It has fibrous tract directly from the spinal cord to the oculomotor nucleus level. Medial longitudinal fasciculus, what that means? Medial means it is located at the midline of the body. Longitudinal, it runs from the spinal cord level to the oculomotor nucleus. And fasciculus means these are the bundle of nerve fibers. And as we've seen, it connects the oculomotor nuclei with one another. It transmits signal from horizontal gaze center to the contralateral medial rectus. It transmits impulses from the vestibular nucleus to the ocular motor nuclei, and it has relay center for the proprioceptive signal from head and neck muscles to oculomotor nuclei. Then we have cerebellum. It modulates the ongoing eye movement and long-term adaptive process and control and adjust the size of the saccades. Then we look for the horizontal gaze center. So the main horizontal gaze center is pyramidal pontine reticular formation, and it gets afferent connections from the contralateral frontal eye field, but ipsilateral parieto-occipitotemporal junction, contralateral superior colliculus, and contralateral vestibular nucleus. So efferent connections are from the ipsilateral abducens nucleus, medial longitudinal fasciculus, opposite oculomotor nucleus of medial rectus, and ipsilateral lateral rectus and contralateral medial rectus is supplied with the efferent connections. If we look for the horizontal saccades pathway, so the terminologies we have to learn is the frontal eye field. The frontal eye field involved is of the contralateral side, PPRF of the same side, cranial nerve nuclei sixth of the same side, medial longitudinal fasciculus of the contralateral side, and cranial nerve third nucleus of the contralateral side. For example, if we want a rightward saccadic movement, that is right side gaze, so for the rightward gaze movement, right gaze movement के लिए left frontal eye field is stimulated and the signals will go towards the right PPRF, that is of the ipsilateral side of the movement. Then ipsilateral sixth nerve nucleus is stimulated, that's lead to the signals to the sixth nerve and to the lateral rectus of the right eye, and then through MLF to the third nerve nucleus. Then the third nerve is stimulated, that leads to the signals to the medial rectus of the left eye. That leads to both eyes move towards the right side. This is the horizontal gaze movement. Next is lesions of the horizontal conjugate gaze pathway. So lesion could be at the level of abducens nerve, so affected side cannot abduct. Lesion could be at the level of abducens cranial nerve nuclei 6, so there will be both eyes cannot look towards the affected side, and that leads to the lateral gaze paralysis. For example, if there is lesion of the left abducens nucleus, so left eye cannot abduct, that is left lateral rectus dysfunction occur, and on the contralateral side, right eye cannot adduct, that is there is left medial rectus dysfunction, as abducens nucleus activates the contralateral cranial nerve third nuclei through contralateral MLF. If there is lesion of the right PPRF, so there will be unopposed activation of the left PPRF, and that leads to activation of the left abducens nucleus and right oculomotor nucleus via the MLF. So there will be conjugate deviation of the eye to the left, and the patient looks away from his lesion. So in the lesion of the right PPRF and the abducens nucleus, same horizontal gaze palsy will be seen. MLF lesion, eye on the affected side cannot adduct when the eye on the unaffected side abducts. This MLF lesion is also known as internuclear ophthalmoplegia. That is, if there is lesion of the right MLF. So, if there is right MLF lesion, right eye cannot adduct, but left eye can look towards the left side. Convergence is intact. Internuclear ophthalmoplegia we have already seen. It is the lesion at the level of MLF. What is 1.5 syndrome? In 1.5 syndrome, there is lesion of the PPRF and MLF both. PPRF of one side and MLF of the other side. Combined on the same side give rise to the 1.5 syndrome, characterized by a combination of ipsilateral gaze palsy and internuclear ophthalmoplegia. The only residual movement is left is abduction of the contralateral eye. Frontal eye field. If frontal eye field is involved, there will be deviation of the eye on the side of the lesion. As we know, frontal eye field involved is of the contralateral side. So if there is lesion, so there will be deviation of the eye on the side of the lesion, and there will be contralateral hemiplegia is also seen. Vertical gaze centers. The vertical gaze center is rostral interstitial nucleus of MLS. The efferent connections it receives from both the cortical ocular centers and the superior colliculus, and efferent connections are from the posterior commissure, nuclei of the third and fourth cranial nerve, and the concerned extraocular muscles. So vertical gaze pathway, there are two pathways. The one is for the up gaze and other is for the down gaze. For the up gaze pathway, as we have already studied that for the vertical gaze, both the frontal eye fields is stimulated. So signals came from both the frontal eye fields. Then we'll go to the both RIMLF, which is the main center for the vertical gaze. Then go to the posterior commissure. Then we have seen the uh, signals from the nucleus of Cajal. They go to the RIMLF, and from the RIMLF to the via the posterior commissure to the other side. So then oculomotor nucleus will be stimulated by via MLS, and then inferior oblique subnucleus will be involved, and for the contralateral fibers will go to the superior rectus subnucleus. So in this we see कि to stimulate the inferior oblique there will be ipsilateral fibers, and to stimulate the superior rectus there will be contralateral fibers, and this leads to the upgaze pathway, and upgaze movement will take place. Next is downgaze pathway. So everything is same for the downgaze pathway. The only nerve nucleus involvement is different. In this, oculomotor nucleus of the same side is involved, and this trochlear nerve nucleus of the contralateral side is involved. Oculomotor nucleus involved that will lead to stimulation of the inferior rectus muscle, and trochlear nucleus involved that will lead to stimulation of the superior oblique muscle, and this leads to the downgaze movement of the eye. Then lesion of the vertical conjugate pathway. There are two syndromes which are associated with this pathway. One is Perinaut syndrome and other is Steele-Richardson syndrome. In Perinaut syndrome, there is lesion at the level of dorsal midbrain that lead to upward gaze paresis. There is loss of convergence, loss of accommodation, and pupillary abnormalities will also seen. In Steele-Richardson syndrome, there is atrophy of the brain that leads to mainly downward gaze paresis, nuchal rigidity, and progressive dementia will be seen in this syndrome. Next is vestibulo-ocular reflex pathway. So vestibulo-ocular reflex pathway. What is this vestibulo-ocular reflex pathway? In this, when there is head movement, the vestibulo-ocular reflex, it stabilizes the gaze by producing an equivalent opposite eye movement to keep the visual target on the fovea. The center is at the vestibular nuclei level and efferent fibers carried by MLF to cranial nerve nuclei. This is vestibulo-ocular reflex. Next is if we look for the example, let's see if the head turns towards the left. So the left horizontal semicircular canal is stimulated. That leads to left vestibular cranial nerve nuclei. First the cranial nucleus, then the cranial nerve nuclei is stimulated. Then it is excitatory to the right abducens nucleus. Right lateral rectus is stimulated and leads to abduction. Via MLF, left oculomotor nucleus is stimulated and left medial rectus contracts, and there will be inhibitory pathway and relaxation of left lateral rectus and right medial rectus, and eyes move towards the right, and that will be the compensation for the head turning towards the left. Then we have optokinetic reflex. It helps to keep the retinal image steady when the entire visual field moves, and it is important for the sustained head rotation or continuous motion of the surroundings. When we first start rotating our head, viewer stabilizes the vision, but it gets fatigued after 30 seconds of continuous rotation, and at this point, the optokinetic system takes over the time to maintain the stable fixation evoked by movement of the entire visual field across the retina. Next is position maintenance system. It maintains the eyes in a stable gaze position. When you fixate on a target, it prevents the eyes from drifting away during steady fixation. And even during steady fixations, eyes are never still completely still. There are small essential movements are always taking place, and it prevents the retinal fading, maintains the visual clarity, and ensures the stable formation. So the clinical importance is defective position maintenance system. There will be fixation instability, which may manifest as nystagmus, poor steady fixation, and saccadic intrusions. Thank you.